So actually the vascular surgery, the way we describe it in the past is different than what we know it now. Any vascular surgeon who is trained, it means he's a hybrid surgeon. He's endovascular, vascular, and a hybrid. And that's the definition of surgery. The surgery we look at 2,500 years ago does not exist now. I always say a surgeon who claims he will do everything by open procedure, he's a general surgeon, he's not a vascular surgeon. So this is completely different. So vascular intervention, the cutting edge, I include the medical therapy, which I leave to my friends, but it is both minimally invasive, open, and the hybrid, which is the advances now. The hybrid procedure in which you can have both endovascular and open procedure, it will cut down on the disadvantages of both. Unfortunately, not many people trying to do that, and pushes the envelope more in both ends, the open and the endovascular. It's got stuck here. So if you look at the practice in the past many years, between 1995 and 2009, look at the practice of vascular surgeons, you will see 2009, everything else coming number one is endovascular procedure compared to 1995, which was open. Even in Germany, the same thing. Everything that is really in the realm of vascular intervention is endovascular, not open procedure. Having said that, this is a study which we are doing and publishing soon. We looked at all revascularization, all of them, the last 6 years, and this is the latest data that we have, administrative data. We found actually revascularization staying the same. Minor amputations are increasing in spite of the fact actually the endovascular technology is improving, the vascular technology is improving, but the major amputations are the same. So we are not hitting anything really. Amputations are the same, no change. So cutting-edge vascular surgery, it started a long time ago with the carotid endarterectomy, and the history we all know, but it extended to stents. And these are very firm results. Actually, there are variations depending on the surgeon, but these are collective results. As you can see, varies from very low to a high. So everything we do nowadays, we have to compare to those results, minus, of course, the morbidity of the procedure. We still all face the same challenges. That's why we fail in surgery, whether it is open or endo. The new intimal hyperplasia, medical therapy that helps longevity, small caliber vessels, and prosthetics. What do we do with those prosthetics devices in case we don't have any venous conduit? What we are trying to achieve, an off-the-shelf tissue engineered graft, and this is coming soon. It's a 50-year actually project that is almost, we are almost there. Use human vascular cells to populate the scaffolds to create vessels for the conduit, and use of stem progenitor cells to populate scaffolds again in order to produce a conduit that can be used using the patient's own cells in order to minimize new intimal hyperplasia. I think it will apply to both endo and open down the road once we find out, or the scientists find out how to solve it. And this has been, as I said, produced by many authors. I'm not going to go through many of them, but these are very small vessels that you can actually produce on the lab and apply to either humans or animals. Most of the studies so far in animals, this is how small are these actually grafts now. So you can remove it from the shelf and put it in a patient. And this is experimental here. You see the blood flow, and after few months or few weeks, 56 weeks, you see that there is no even change in the anastomosis areas in a very small vessel. And this is great. Once we have it on the shelf, things will change in the open. Then we have multiple engineered vascular grafts. Nowadays with the printers, the 3D printers, you can print anything you want. The good thing about it, actually, you just put the scaffold, print whatever you want. And the good thing about it, that those printers, you can have different sizes. Like if you want to fit different vessels, different sizes. And again, it's coming down the road. Once it is accelerating now to put it on the shelf. And there are different ways of doing that. Then we have the decellularized conduits, in which you take the vessel and decellularize it completely. Don't put anything and put it in the patient. It causes thrombosis, but add the progenitor cells to the conduit, then you will have much better result. again, the longevity will be very high, and there are multiple actually forms for that that's been under study and evaluation. Some of them actually using a tubular form, some of them using different forms to produce. What about the hybrid procedure? For any clinicians, if you have both, you can do the hybrid procedure. It will improve the outcome of the procedure, improve selection of the procedure, and provides the best of the two worlds. Each one of them has advantage over the other. So if you combine them, you get the best result, which actually overcome both the open and the endo procedure. There will be no change in the technique how to do, because this has been perfected. Whether it is carotid, whether it is aorto by fem, there's nothing beyond that. It's how to deliver it to the human body is the change in the future. And these hybrid procedures are really better when you combine above and below the inguinal ligament. And if you look at the combined, these multiple procedures are done, we use it a lot, we never report it because it's taken as natural. This is the way it should be done. I'm sure if we want to report our group will be at least 50 to 70 procedures a year, but we don't report those data. Hybrid procedure, lower and upper extremities, mesenteric arterial occlusions, which usually fails endovascular. You make a small incision, deliver the vessel outside, an endovascular approach without doing the bypass. This is again a new procedure. Portal veins, we did many lesions actually in the portal vein with their tumors, thrombotic occlusions, by pulling the intestine through a 5-centimeter incision and cannulate one of the veins, open technique, and do anything you want without avoiding going through the jugular vein, inguinal vein, or going through the liver, and the patient can be done under local anesthesia. Patient then can go home next day. So these are minimally invasive that we can use that both endo and open failed when you combine both of them together. We use it in TIPS procedure, difficult TIPS procedure those. So the advances in chemical bonding of grafts, drug coating, genetic engineering, tissue engineering, stem cell coating, they are all coming. And robotic surgery, although many people tried it, I will not advocate it really, but it is one thing that you can use it minimally to achieve higher end result if you know how to do robotic. And this is an example of some papers. They use an aorto by fem, aorto-iliac bypasses through small incision, minimally invasive. Next day, patient is discharged. So the cutting edge surgical revascularization, it is really nowadays paralleling endovascular. What we learn from endovascular, we are applying it to open. Things to reduce neointimal hyperplasia. Endovascular led the way in this, but it is being applied to open. Open techniques has been perfected, so there will be not change. How am I doing it retrogradely, antegradely, forward? This is according to the preference of the surgeon, but again, bad surgery give bad result, whoever is the surgeon. Thank you very much.